Hello and welcome back to another episode of the Oncology Brothers podcast. I'm Rohit Gosain and here with my brother and co-host Rahul Gosain. ESMO 2025 just wrapped up with thousands of abstract and exciting science that was presented. Our goal today is to focus on practice-changing and informing studies from those that were presented and walk away from big takeaway messages from the world of lung cancer. We are very excited to be joined by a friend, mentor, and leader in thoracic medical oncology, Dr. Rami Manochakian from the Mayo Clinic. Rami, thanks so much for joining us, sir.
Thank you so much for having me. And once again, I always like to start by giving you kudos on what you do. It's just amazing, the education platform that you run to help many oncologists out there take better care of patients. So congratulations.
Rami, welcome. And as always, thank you so much for your kind words. Okay, so for everyone listening, over the next few minutes, we'll touch on MDT-Bridge trial in early non-small cell lung cancer, then switch gears to FLAURA2 update for EGFR-positive disease, and then close off with HER2-positive non-small cell lung cancer. Rami, can we start off with MDT-Bridge trial? This is in borderline resectable non-small cell lung cancer. In these settings, our options are a neoadjuvant approach with Checkmate 816, which is nivolumab and chemotherapy, or peri-op and post-op approach based off multiple studies, or Pacific trial if this is truly unresectable. Can you walk us through this study and its findings?
Yeah, absolutely. Thank you so much for bringing this study among many amazing studies reported in ESMO 2025. So this was a global phase 2 studies. I really like the concept here. As you mentioned, there's so much happening in this field of neoadjuvant, peri-op, for those resectable, locally advanced, patient with non-small cell lung cancer. We know is the, jury still out on the neoadjuvant only versus the peri-op. That's a whole talk and ongoing debate. But what I like in this study is testing the concept of a hard-stop multidisciplinary assessment throughout the process, a reminder for all of us to do better for our patients by making sure we're always reassessing where they are in the treatment journey. It was, a study that basically, tried to label patient as whether they are resectable, stage 2B to 3B versus borderline resectable. And we encounter this in our clinic every day. Yes. Giving them basically a chemo IO, in particular, platinum-based, with IO for 2 cycles, nivolumab in particular, for 2 cycles, then reassess where they are and see, are they still deemed potentially resectable versus, maybe not, especially among the ones who initially they were reported maybe borderline. If they deem resectable, go ahead and give 1 to 2 more cycles, to complete total of 3 to 4 adjuvant if you want, given 1 every 3 weeks, then go to surgery. Or if they were, deemed by the evaluation that those cannot be resectable, then proceed with the, concurrent chemoradiation therapy. So kind of like that concept, for us, as opposed to the, just give everything up front, the 3 cycles or the 4 cycle that we're used to. Seeing where we are was very helpful. What we're seeing here, what I think is fairly impressive result. I mean, first of all, majority of the patients, I think overall, the resected ones were about like 85%. And the other numbers that I like to see, so the primary endpoint was resection, were these resected or not? Among the one who were deemed resectable, overall later on, 95%, after the first assessment were deemed that they're still resectable. And among the borderline resectable up front, about 82% were felt to be resectable. Not everyone ended up getting, resection. I think, reading the numbers, overall finally was the 92% of the overall resectable got resected and about 71% of the borderline got resected. This is excellent numbers to tell us that a large percentage of patients could undergo surgery. Many of us out there believe that surgery yields some excellent outcome for these patients. Regardless of the neoadjuvant peri-op, we know IO plays a significant role. The surgical outcomes were very close to the peri-op EGAN trial, which used nivolumab, Most of the resections were R0s. Patient majority of them did very well. And for those who could not get surgery, proceeding with standard concurrent chemoradiation was still a good option. And that trial design did not affect or hurt in order for them not to be able to get concurrent chemoradiation. So all in all, good design, good concept. I like what we're seeing.
Thanks so much for breaking down that, Rami. With regards to what this study shows is the importance of multidisciplinary in all stages of non-small cell lung cancer. As you stated, surgical resection is extremely important. And if one is not able to go for that, well, that's where radiation fits in. What we are seeing is, again, as you stated, with the peri-op studies, what we also saw at ESMO was the overall survival from Keynote 671, where at 5 years, which was an update, which we are seeing about 65% of these patients do well with pembrolizumab therapy, which looks rather similar to what we have seen with neoadjuvant treatment. And of course, not to forget NGS testing, where we do have patients who have common EGFR mutation. One should utilize osimertinib in adjuvant setting. And also, if ALK positive, then relying on alectinib. All right, moving along, great segue to focus on our next study, which is FLAURA2. Here we have chemo plus osimertinib versus osimertinib in common EGFR mutations in frontline settings. We had seen initial data of this at World Lung, and now what we are seeing here is more overall survival in different subsets. Rami, your thoughts, particularly this concern of CNS disease, because this is rather common in non-small cell in metastatic space.
Yes, absolutely. Another landmark important study is we know we got some of it on during World Lung 2025, and now some more updates. Patient with advanced non-small cell lung cancer with EGFR mutation, in particular, the most common exon 19 or LT858R. I mean, the last couple of years, give or take, right, we've been having this ongoing debate with a lot of new options for these patients, especially the combination. Osimertinib has been the standard of care for quite some time with excellent outcomes, but we do know that good number of patients at some point, their disease become, resistance and their cancer progress. So the so-called combination, therapy upfront is what is being now talked about. We have the amivantamab, lazertinib, another whole option that is excellent option also that needs to be offered for patients with excellent overall survival data, discussing toxicity and so forth, which is a big topic. And here we go, we have the FLAURA2 that is testing osimertinib plus chemotherapy, carboplatin or cisplatin with pemetrexed, the most common regimen used in patient with stage 4 adenocarcinoma. Impressive results. We've seen initially the progression-free survival. A while ago, we were all anxiously waiting for overall survival data. And, the least to say, definitely impressive result showing, significant, clinically meaningful and statistically significant improvement in overall survival with hazard ratio of 0.77 with a median overall survival improvement of about 10 months. Seeing the OC plus chemo reaching a median of 4 years, we all need to take a moment here to pause, whether with this data, whether with the Mariposa of amivantamab lazertinib, to feel so good about these, number of patients who are now able to survive multiple years on this combination of treatment. Most importantly, in the updates here, of course, the subset analysis. Where is this combination needs to be considered? Where is it showing the most benefit? The patient with high risk features or more aggressive disease, CNS metastases. Look at these outcomes where these patients are doing better on the combination. Patient with liver metastasis, patient with a TP53 co-mutation, patient with circulating DNA showing EGFR mutations. This is definitely, in my opinion, a standard of care option that we owe it to our patient to discuss it, discuss the Mariposa regimen, and discuss osimertinib as a single agent also as a potential option, keeping in mind patient, including patient in the decision making, but also present the data to them and help them and guide them, make a decision, especially in those high risk features. And last thing I would mention is also that, overall the toxicity profile was what we were expecting. I don't like to use the word manageable or acceptable because some patients may really get a hard time or have issues with the toxicity, but it is what we're expecting. With optimizing toxicity management, we are able to help some patients. And last but not least, good number of patients did not need to be on a chemotherapy, the maintenance pemetrexed for a long term, something to keep in the back of our mind.
Absolutely. These are exciting times. Again, because of this, our patients are living longer. So just to recap, in this space, we now have two potential combinations, amivantamab with lazertinib and chemo with osimertinib. And this is what we're seeing with the updated overall survival. And on our end, we've recently covered this space with Dr. Eric Sengi in our challenging cases. So before I move on from this topic, another study, North Star, was a phase 2 study presented at ESMO, where we saw that adding local consolidation therapy showed improved overall survival in the same patient, EGFR mutated disease. I would like to believe, Rami, that a lot of us are already doing this today in our practice, but now we have more data to support this practice.
Yeah, I'm so glad you mentioned it. I think it was another important study that validated, to your point, what we're already doing. Local therapy is very important. We have, different, research, a lot of, scientific rationales why it would be helpful to consider for patients with not just oligometastatic disease, but even some patients who have actually multiple or, polymetastatic, is to consider some local therapy, whether radiation or surgery, to add to the effect of the systemic therapy. We've seen significant improvement in median progression-free survival. I think it was about 17 versus 25 months, looking at these, number of patients, wherever they got. Some percentage got surgery, radiation, or both. No major adverse event or a new adverse event. I think it's something we need to consider on a case-by-case for every patient. And I'm not talking about the oligoprogression, which we all know. Yep. We're talking upfront. Many of us believe to maximize outcomes and survival, including some local therapy, is the way to go, not just in this particular, patient, EGFR, even in other lung cancer or even other cancer, to keep a local therapy as an option to be offered.
Absolutely. And Rohit, there was a reason you mentioned that multi-D is important every stage. This is yet another example.
Because these interventions are rather leading to increased survival.
Absolutely. All right, now let's pivot to our HER2 mutated non-small cell lung cancer, which is often reported as ERBB2 mutation on our NGS. We initially had TDXD here, and then Zongertinib, recently approved. We'll likely see Sevabertinib approved here as well, based off SOHO-01 study. Rami, SOHO-1 update was presented at ESMO. Can you touch on this study and its findings?
Absolutely. What an era we're living in for patients with lung cancer, particularly non-small cell lung cancer, is, again, take a moment to echo what you guys already mentioned also at the beginning, a reminder for us of the importance of NGS testing. I know here we are probably, preaching the choir, but there's still some patients out there that they're not getting the full testing. So let's always keep helping these patients out there spread the word. Every patient with advanced lung cancer, non-small cell lung cancer, especially adenocarcinoma, next gene sequencing testing, so we can pick up some of the common mutation and some of this mutation that might be more rare, HER2, not necessarily a mutation that you're going to see every day in clinic, but there are some patients that you're seeing today or tomorrow in clinic that they're going to have it in their cancer, and we need to pick it up. Historically, we didn't have much for this particular mutations. And then, like you mentioned, the TDXD approved in the second line. And with the first line, we use some typical, IO, chemo IO, although we don't believe that IO may work a lot in those patients, although in some patients there might be. So we had this study is looking another oral TKI, that is overall, I would say again, if tolerability is very important, especially with TDXD, we know there is some toxicity issues. I would like here to say that it's a tolerability that I like to call it a favorable in general.
Yep.
Again, we understand some patients, unfortunately, may get some major side effects. And this is looking at this oral therapy in, different cohorts for patients with HER2 mutations. Again, impressive efficacy outcomes. This looked at cohort of patients who are treatment naive, who did not receive any treatment, response rate about 70-72%. Looking at patients with pre-treated, but they did not receive a prior HER2, drugs. Again, response rate in the 65%. And then the one who were pre-treated with another HER2, we're still seeing some good response, about 38 to 40%. And in all these cohorts, another good patient population with a clinical benefit rate, which in my opinion is also important. Grade 3 or above adverse event about 32%. So, historically, that's not too bad. We know that diarrhea here is something to notice, more compared to other drugs. But all in all, like, discontinuation rate was very low, I believe around 2 to 3%. I think this is an effective drug. This is a drug that seems with acceptable tolerability profiles. I think this drug is going to play a role when approved in treatment of such patients.
Indeed, Rami, I want to reiterate the point about NGS testing. One needs to do that upfront, but also to catch some of the resistant mutations on progression of the disease. Another TKI in space here, which is an oral regimen with favorable side effect profile, especially when you're comparing that with T-DXd, which has almost like chemotherapeutic side effects like fatigue, alopecia, and not forgetting about ILD. Rahul, I agree, this will likely get approved soon. Rami, can you touch on our last study here, that is Beamion LUNG-1, as this is what led to the approval of Zongertinib. What we would like to know is, if all these are available, that is Sevabertinib, Zongertinib, and now, of course, T-DXd, how are you sequencing them?
Yeah, absolutely. I mean, great questions. And this is, again, another ongoing debate, a good problem to have. I think, we're heading soon to the era where, HER2 drug is going to be used in the first line. We hope more larger studies continue to validate, and ultimately we get a potential FDA approval with this impressive data that we've seen with SOHO-01. And now the Beamion LUNG-1, this is a good segue about Zongertinib, which is a drug currently approved after progression on chemotherapy in particular. Some of us already using it before the T-DXd. And honestly, I can tell you right now, especially as of the last few months, it's becoming my preferred agent to use in the second line after potential first line IO or chemo IO majority. This study here, the Beamion LUNG-1, is giving us the result of cohort 2, where it was a first line, given first line, which I think it should be. Again, another oral TKI, and response rate, with 77%. I mean, this is amazing. Even when we look at all targeted therapy, the disease control rate in the high 90%. This is us saying every patient benefiting of this drug. The overall, the toxicity profile, I would say, favorable. I mean, again, we can't compare studies with each other, but relatively speaking, those of us who, whether we're under trial or started using it in practice, we can attest to that. That doesn't take away that we always should do everything we could to address all the symptoms, quality of life. Every patient, sometimes even a minor side effect could turn their life, cause major issues. The study also reported 6 months, I think, duration of response, about 80%. So this is a durable response and then the progression-free survival, again, 6 months median, or 6 months, I should say, about 80%, 79%. It's just another very effective drug that we think patient would be able to tolerate. And this drug already approved in the second line. I think this drug could be used in the first line. Leading to your excellent question, I often keep repeating the same sentence, a good problem to have. How are we going to sequence them right now? I've been in touch with colleagues and some companies to try to see, how do these drugs do after each other? Is there any data? Are we going to get any more data? I see myself sequencing some HER2 drugs and not necessarily going into chemo IO, maybe later lines. There are more potentially coming in the pipelines for such a rare mutation. If I look at the two studies, it seems like Zongertinib and the Sevabertinib, both in the first line, have very close efficacy data. Discussed based on patient factors, the potential profile, other factors. Would I sequence them one after the other? Would I use a T-DXd? Possibly. Could I use the three of them? I think this is going to be an ongoing discussion. As long as we declare to the patient that some of these sequencing, we don't have great data exactly to look at it. But we think that HER2 potentially could be more like the ALK, where, one HER2 drug after another could still work. I do recommend potentially rechecking the NGS, ensuring there is no new resistant mutation, no transformation, no other things to do when you're treating such patients.
Right now we're stuck with cross-trial comparisons, but when we're putting these two studies side by side, that response rate and CNS activity by these oral TKIs is very impressive in frontline and in refractory disease. And a few things that were brought up, we have to keep side effects in mind. With the oral TKIs, Sevabertinib or Zongertinib, rash, diarrhea, fatigue, whereas with TDXD, which is IV, you have to keep ILD, fatigue, nausea, and alopecia in mind. Rami, we've covered a lot here, but before we wrap, any final thoughts around ESMO or another study that caught your attention?
I'm actually going to use one of the things you mentioned on my final thoughts, the CNS activity in these drugs and a lot of these other drugs that we're seeing. Today we discussed 2 targeted therapy for HER2, the FLAURA2, and we're seeing these sicker patients who have more morbid disease, CNS, which has always been the ones that are that hard to manage and they don't respond well to systemic therapy. We're living in an era to see now a lot of other new targeted therapy or different combinations are able to reach and to attack these cancers and metastases in the toughest area, especially in the CNS. We have some data in the leptomeningeal. So yes. I'm excited. Meetings like ESMO's 2025 and other great meetings are where some practice changing, or informing trials are being presented, remind us that while we have a long way to go, but we also have made so much progress in the fight against lung cancers. There's a lot of other studies were presented, a lot of talk about the Harmony trial, Harmony 6 trial in a squamous cell carcinoma, another area of unmet needs, which created a lot of buzz, a lot of debates. We know this trial done mainly in a part of the world in China. We have to be open to validating trials. We like to see the concept of this bispecific VEGF and PD-1, to see a drug to have such efficacy is exciting. Waiting for more data to come, but it's only the beginning. The last 5-10 years, we have seen just a plethora of a study of exciting things with ultimately all great goal to help these unfortunate patients. There is no better time to be an oncologist. I'm sure you agree.
Absolutely.
Indeed, Rami. These are exciting times as an oncologist as well as patients and their families, where we are seeing about close to 40 new drug approvals each year in the hematology-oncology space. And we saw what you stated, very exciting ADCs and bispecific here at ESMO in lung cancer space. But what you stated, though they were in China, but they are telling us that the science is effective. So we need to have a broader or global audience being involved here, and we'll have to wait for the mature data as well. Rami, thank you so much for taking the time to go through these important studies that were presented at ESMO from lung cancer space. For our listeners, let us go over a quick recap.
In this discussion with Dr. Rami Manochakian from Mayo Clinic, we focused on lung cancer abstracts from ESMO 2025. MDT-Bridge study stood out as it provides a little more guidance on what to do with our borderline resectable non-small cell lung cancer patients. It continues to reiterate the importance of multi-D approach. Then we touched on FLAURA2, which confirmed overall survival benefit from Osimertinib with chemotherapy in almost all subsets for our EGFR mutated disease, keeping our combination options of Amivantamab and Lazertinib or OC with chemotherapy in this settings is important.
To close, we covered our HER2-positive non-small cell lung cancer space, where we currently have Zongertinib and TDXD available, but very likely we will see Sevabertinib in this space as well, given phenomenal overall response rate and its favorable side effect profile. Thank you all for tuning in. Be sure to check out more of our episodes from practice-changing updates, new approvals, and major conference highlights. We are the Oncology Brothers.